going to be just a teaser for thrombolysis in the eMERGE. We're going to have Dr. Drew Thompson talk about some of the cases to stimulate your interest in critical thinking, and then Dr. Carl Theakston is going to talk about two of the recent or the big trials. Not necessarily a full critical review, but a review of the trials. And then we can proceed into a large group discussion or panel discussion where we can finally ask all your questions. So we'll start with Dr. Thompson.
Actually, it's not an arrest over there. It's usually someone that vagaled or just doesn't feel well. But this was a true cardiac arrest. It was a lady that had just had a ENT surgery, a uvulopalatoplasty, 24 hours prior. She was only mid-30s, but was feeling unwell the next morning. She went out for a smoke because she wanted to get more air. Didn't do so well coming back from her walk. She was a little bit tachycardic, didn't look good, and boom, arrested. So I arrived mid-arrest as part of the emergency response team as CPR was ongoing. She was in PEA. And to be fair, there was really no other cause for her arrest. We know she hadn't been bleeding. We didn't have anything else in our differential diagnosis, and now we're 15 minutes into a PEA arrest. This was before the advent of point-of-care ultrasound, which you all know I'm a fan of. And I made the decision to lyse her empirically because of tachycardia, some borderline SATs that morning, and a sudden arrest. Lo and behold, we got a return of spontaneous circulation within 6 minutes, and she did really well. She had some bleeding post-operatively, but she went home. And I remain convinced to this day, this is my one case where I made a difference. No one else was going to thrombolyse her and collapsed. Bystanders were great. They checked for a pulse, and they immediately started CPR. When EMS arrives, he's got a GCS of 15. He's alert and oriented, and he's going, I got a lot of pain, and presumably from the CPR. He arrived at the emergency room with a heart rate of 128. Oxygen saturations were not great on a non-rebreather. And when you ask him, although it's hard to delineate from the chart, and I won't get the physicians involved today involved, it sounds like he had chest pain for at least 12 hours prior, maybe a little bit longer. He's on no medications. This is his ECG, and we're not going to belabor diagnostic elements of all of this stuff, but he interestingly has the S in 1, Q in 3, and an inverted T in 3, and his blood work. I won't get into the diagnostic kind of processing that went on, but the physician was astute. For some reason, there's a D-dimer on the chart. I won't get into whether or not it was needed or not. Troponin of 288, but regardless, the right test was done. And someone went after PE, and I'm no radiologist, but that doesn't look like there's blood going in through here on multiple images. And he was diagnosed with an extensive pulmonary thromboembolism, overall large clot burden, and CT evidence suggestive of right heart strain. This is part of the diagnostic criteria for submassive or intermediate risk PEs, as Dr. Theakston will get into briefly. So he comes back from CT, heart rate's 128, blood pressure's 108 on 73. Would anyone here consider fibrinolysis, thrombolysis? He's got right heart strain, evidence of damage with tropes, and let's be fair, he probably died, but the CPR got him back. So who would do fibrinolysis? I realize not every systolic arrest. It took us about 5 minutes as we rushed into the resus room. He started waking up and sort of swatting people away from his chest in the bag valve mask. And he had a slow return to his level of consciousness. He actually became quite alert again and talking. He remained a bit dusky, heart rate 128. Blood pressure we think was about 70 on 30 systolic. Hard to tell, we didn't have an art line at that stage. We weren't really sure of his SATs, we couldn't pick them up, and he did look kind of like the color of your chair. Fibrinolysis now? So maybe more, although a lot of you were going to do it empirically initially. So what happened with this guy, he was subsequently transferred to the ICU very shortly after this arrest. They did get an art line, confirmed his blood pressure, and he received TPA, improved his color and hemodynamics within an hour. During his stay, he was diagnosed with bilateral DVTs, and he was discharged neurologically intact, functionally intact, day 9, on Fragment with thrombosis clinic follow-up. So an interesting case of one issue. Normal blood pressure at one point in time, yet has a bad disease. Low blood pressure at another point in time has the bad disease. And does that make a difference in whether or not you should choose to thrombolyse? A case that hits a little kind of closer to home because I was intimately involved with this one. 23-year-old lady who was otherwise perfectly healthy. She is on the birth control pills, I'll show you in a second. She'd been feeling unwell for a couple of days, is the story we got from EMS. She yelled out to her brother, "Go get mom, I don't feel right." Brother went upstairs to get mom. By the time they came down, she was seizing. The seizure lasted for about 2 minutes, and then she stopped breathing 2 minutes later. EMS was activated. This is not a girl with a seizure disorder. Bystander CPR was performed. EMS arrived, found her in PEA with a ventricular escape, and after about 8 minutes of endotracheal intubation, some epi, the usual ACLS standards, we got back to a ROSC. She arrives in my emergency room with a heart rate of 130, a blood pressure of 130 on 62, satting reasonably well on her 100% through an endotracheal tube, and her GCS is 3 or whatever it is with a tube. I sent her for an immediate CT head within 3 minutes of her arrival because I heard seizure, loss of consciousness, the breathing I wasn't sure. She's perfectly fine here now, but she's not awake. Sent her for a quick CT head. While she's over getting her CT head, parents come in, appropriately very concerned, tearful, everything. She had collapsed 3 days ago. She was out for a run, she blacked out, fell on the ground, got her wits about her, and sort of made her way home. Since that time, she's been feeling really anxious. She's kind of fearful about everything. She went to her family doctor yesterday, who started her on Cipralex and lorazepam for her new diagnosis of anxiety. So when I heard that story, I was a little concerned. So as she came back from CT, we put on the point-of-care ultrasound probe. And this is not a POCUS talk, although I'd love to talk about POCUS. A bad parasternal long-axis view, although it tells the tale. This is her RV in the near field, probably her left atrium and her aortic outflow tract here, and this is her LV. I think we can appreciate that her LV really has no fluid in it. Her RV is occupying way too much space in this section. So she has RV dilatation and an empty left ventricle. This is the view you're a little bit more used to, the subxiphoid view, where we see the RV is certainly bigger than the LV. So already we have our diagnosis in mind. I think I know exactly what's going on based on the story and what I have here. We sent her, I guess we got some blood work on her too. Interim. She obviously had arrested and stopped breathing for a while. This is immediately as she walked through the door. Nothing else of note, really. No tropes, no dimers. So what does she have? Bilateral pulmonary emboli with a large clot burden and evidence of increased right-sided heart pressures. She comes back to the emergency department. Heart rate of 126, blood pressure of 140 on 88. Who would fibrinolyze this lady? Thrombolyze this lady? Kind of a few less people now. I had planned to give her fibrinolysis. I had told the family I was going to do it. As I was sort of preparing, getting the drug to the bedside, ICU arrived. As ICU arrived, they had the very appropriate discussion saying, she is no longer an unstable patient. So should we fibrinolyze her or not? She is not in the arrested period, peri-arrested period, or unstable period right now. And so we had a collegial discussion, and she was not. She went up to the ICU. It raised a totally different question for me, which is an appropriate one for the hospital dynamics, which is who follows up the patients that Emerge initiates care on, and can I realistically initiate care when we have a disagreement and the consulting physician, through MRT, disagrees with me. So we had the collegial discussion, and they were going to reassess her up in ICU, which is required for prolonged inotropic support. By day 4, they're having difficulty with oxygen saturations, with things that look like pulmonary infarcts. She was still on some inotropic support. Oh, Lord. I don't know how to fix that. Help. I know, but I can't get to my mouse on that now. So I can get that scene. Oh, thank you. Oh, I'm going to skip the version. Sorry about that, guys. What you said, but I'm going to ignore it. So on day 4, they consulted CT because they were having difficulty managing her. The decision was made to do an open pulmonary thrombectomy. That was the that was made. I know there are other management algorithms that I won't get into, but regardless, Day 7, she was off her pressors. She was discharged day 14, and from all accounts, doing well in follow-up, as much as well as having had an open procedure. So our last case, this is a 60-year-old male. He is 4 weeks post-ankle surgery. He's had 2 days of increasing shortness of breath on exertion, but really no other symptoms. He just walked in like every other average bear that comes to the emerge, saying, look, I feel a bit short of breath. And he comes in with his air-cast boot on. His triage vitals, heart rate of 110. He is hypotensive at 90 on 58, breathing about 24, and he's requiring some oxygen to maintain his SATs around 92, 93%. In terms of the bedside assessment, this is a funny dude. He's cracking jokes. He is not in any distress. I was actually belly laughing a couple of times with some of the things he was saying, most of it inappropriate for today. He was a bit tachypnic, but he was a very comfortable looking guy. And as I say, you see his air-cast boot. No other past medical history to speak of. His ECG, for whatever it's worth, just to bring up that 2-wave inversions we classically associate with ischemia, but they can go along with PE. We won't belabor that point. Again, a point-of-care ultrasound was done, showing at least an interesting finding. Anyone want to comment on the finding? RV, LV. RV is certainly bigger than the LV in this apical 4-chamber view. And there is an interesting finding where the apex itself is kind of being overridden by the RV, and there's sort of an asymmetric contraction, something called McConnell's sign, which is associated with PEs, although it is associated with other features as well. But certainly a compelling bedside ultrasound to tell me this guy's going to have a significant PE. Just because I had a little bit of time, we went down into his legs. This is his popliteal vein and his popliteal artery. And just on simple bedside compression, it's obvious that he doesn't have any compression of his popliteal vein. And blood work, again, not very helpful, a troponin of 33. What does he have on CT? Extensive bilateral pulmonary thrombus, very large clot burden, and enlargement of the RV, bowing, again, RV strain. How about this guy? He's now sitting there, heart rate of 110. His pressure is 89 on 57. Feels great. You have that CT. Yeah, I know. I just have to push the envelope a little. Yeah, it changes every minute. So whether it's 89 or 90, who would thrombolyze this guy? Weaker hands. Probably the same number, but just a little weaker. So fair enough. So he was not lysed. He was referred to medicine. He was treated in the usual fashion. He was confirmed to have a popliteal DVT. He received his fragment very quickly. He was off O2 by day 3, and he was home on day 4. And again, fragment with thrombosis follow-up. So I hope these cases kind of just give you a spectrum. They give you a spectrum of probably a sicker patient by parameters of RV, by troponins, by some hemodynamics, some that were ultimately very unstable and probably dead, and some that were not so unstable, or maybe unstable by their number. So what do we do with these patients? And that's really the question that Carl's going to review some of the papers on, which is these massives or intermediate risk PEs, and should we be getting involved and being more aggressive with them?
Okay. Can everyone hear me okay there? Yeah. So thrombolysis or thrombolytic therapy in submassive PEs is a very controversial area. And I feel like I've kind of been thrown to the lion pit this morning. So let me just proceed. This is a controversy, as I said, and I've been asked just to give a very brief summary of the literature. I don't have the time to go into each study in great detail to do a critical appraisal, so I apologize for that. I'm just going to kind of whip through a number of what I think are the most important recent trials, try and address this controversy. To start with, it's important to appreciate that pulmonary embolism is different than the usual kind of clot occlusions that we're usually dealing with. So STEMI or a stroke. Remember the difference are arterial occlusions. The issue there is ischemia. Time is muscle, time is... This is not PE. PE is an obstructive thing. It's not an arterial ischemic issue. And because of that, the usual rules that we kind of think in our head when we think about clot obstruction probably do not apply. The other thing to appreciate is that thrombolysis is of uncertain benefit in non-massive PE. And thrombolysis, we do know, increases the risk of ICH and serious bleeding. This issue, the issue of thrombolysis for submassive PEs, comes down to a risk-benefit calculation. And I will get into that in a little bit further in my closing comments. I want to touch on these recent trials, the Moppet Trial, Topcoat, Pizzo, and there was a recent meta-analysis done. And I will touch on that, although I will not go into great detail in the meta-analysis because it would take too much time, but I will touch on it. So the Moppet Trial, published in 2013, I think is really the trial that for emergency medicine started some of this controversy going, made us start to think, are we doing the right things with these patients? The authors of that trial decided to use what they considered safe dose thrombolysis because it was known that thrombolysis increased the risk of bleeding, and so they wanted to try and avoid that complication. Say, listen, if we give a safe dose and there's really no risk of bleeding, hey, thrombolysis probably is a good idea for these submassive PEs. They used half dose or 50 milligrams of alteplase in patients with evidence of pulmonary hypertension in moderate PE. Randomized trial, single center, open labeled, and a small trial, 21 patients. Randomized, 61 got to thrombolysis and the control group was 60. This trial was not powered for mortality. And the outcome assessors, and we'll get into what the outcome was, were blinded. While it was an open trial, the assessors were blinded. These are patients who are normotensive, symptomatic, and their definition of moderate, and it's important every trial you look at on this subject to look at what their definition of moderate or intermediate risk is. In this trial, it was an imaging definition only. And their imaging definition was they had to have 70% clot involvement of either the right pulmonary artery or the left pulmonary artery or two smaller segments, two lobes that were 70% involved. So one big one or two smaller ones. Or if a VQ was done, two lobes or more involved. You obviously can't assess the amount of involvement in the artery, but that was their definition of what they called moderate. Notice that this is not a clinical definition. They have to be normotensive, they have to have symptoms of PE, and they have to have these imaging findings. And by their definition, that made them moderate PE. Safe dose or half dose TPA was given. You can see how it was given, and they were all started on enoxaparin or unfractionated heparin. My recollection is that 70% of them were given low molecular weight heparin, 30% were given unfractionated heparin. And the same sort of ratio for the control group. They were all started on warfarin on their admission. So what were the outcomes? The primary outcome was determined at 28 months, so a fair bit of time, like over 2 years, and their primary outcome was the incidence of pulmonary hypertension, defined as a PA systolic blood pressure greater than 40 millimeters, on an echo. They also had a second primary outcome, which was a composite outcome of the incidence of this pulmonary hypertension by this echo definition or recurrent PE. So that was their composite outcome. They had a couple secondary outcomes, including safety outcomes like bleeding. So here are the results. So what you can notice is there is a statistically very significant and obvious difference in the incidence of pulmonary hypertension. These are normotensive patients. These are patients who had, we would say, a significant clot burden on imaging. And when they were followed up at 2 years, the ones that were thrombolyzed had dramatically lower pulmonary artery pressures. There is no clinical variables here. This is simply an echo on follow-up and an imaging at the beginning. If you also look at this, you'll see that the mortality was not statistically different. 3 versus 1. If you look at the mortality plus recurrent PE, which remember was one of their pre-specified primary endpoints, it just reaches statistical significance. And that's because there were 3 recurrent PEs versus 0 for the treated group. Also interestingly is there's a statistically very significant difference in the length of stay. Hard to know what to make of that given that it was open label trial. So the conclusions from the Moppet trial are that there's no mortality benefit, but it was clearly underpowered to look at that issue. There's a significant reduction of pulmonary hypertension at an intermediate time frame of about 2 years or so. The clinical significance of that is unknown from this trial. And there were no intracerebral hemorrhages on this thrombolytic dose. So in neither group were there any strokes or bleeds. So one of their conclusions was this is kind of a safe thing to do. Wasn't a big trial, but again, they did have no bleeds. This paper got people very excited. Let me jump forward to the next trial, Top Coat, also published in 2013. They used full dose TNK plus low molecular weight heparin versus low molecular weight alone in submassive PEs. Multi-centered US trial, double-blinded, randomized, placebo-controlled. Small N, 84 patients only. Clearly underpowered study. And the reason for that is the study was terminated early, not for any clinical or statistical reason, but because of politics, administration, and the primary investigator changed institutions and was unable to continue the trial. It was originally scheduled to have like 160, so basically half of the enrollment. So it was underpowered for its primary outcome, underpowered for mortality. Unlike the Moppet trial, which looked at no clinical variables, and this was Jeff Klein's paper, he decided to include, because he wanted to address the issue of patient-oriented outcomes. What really matters to the patient? So he has a very complex composite outcome that does include a whole raft of patient outcome oriented outcomes, which I'll show you. So in their study, adults with submassive PE, defined as a PE on CTPA, normotensive, and evidence of right ventricular strain, which is hypokinesis on the echo, an elevated troponin, or an elevated BNP, any of those things. So normotensive, PE, and evidence by some measure of some RV strain or injury. All patients got low molecular weight before randomization, and it was a weight-based bolus, single bolus TNK or placebo. So here is a break. This is a difficult results thing to look at, because remember he has this very unusual composite outcome that includes things like poor functional capacity, which was measured in a 6-minute walk test. Low perception of patient wellness, which was done by an SF-36. These were at 90-day follow-up. Recurrent VTE. And within the first 5 days, they looked at death and shock or intubation. So this is probably not maybe the best way to have a good primary outcome, but if I show you this slide, you maybe get a better sense of what they sort of found, is that people who got thrombolysis, 85% of them had none of those markers of badness. They had they felt well, they had no evidence of functional capacity impairment in follow-up, they had no death, they had no recurrent VTE. So, and in the other group, they got placebo, 63%. And there was a whole combination of things that took away from that amount. You can see this part here is much bigger. It's a collection of all kinds of things. And his point was, what percentage of people that got thrombolysis at the end of their treatment felt well? And that's what he was kind of looking at. And he showed this statistically significant difference to suggest that thrombolysis improves patients' outcome. The other thing is they also looked at a length of stay in hospital. This was randomized and blinded. And interestingly, they found the same thing as in Moppet. People went home earlier. So presumably there is some effect of thrombolysis on the things that allow us to make decisions to say, hey, I think you can go home. The conclusions from Topcoat are there was an underpowered study for mortality and their primary outcome. No mortality benefit. There was a death in each group. One death in the TPA group was from a bleed in the head, and the one death in the control group was from PE. There's one death each. They kind of bounced each other off. So no mortality benefit. There is a suggestion of improved functional status and patient wellness, though. And the point estimate of hemorrhage here was 1 in 40, so about 2.5% likelihood of an intracerebral hemorrhage. The paper that everyone was waiting for and was published last year in the New England Journal is the Pizzo Trial. It is by far the largest trial that, again, is probably our best current evidence that looks at this issue. This was a multi-center, double-blinded, placebo-controlled randomized trial. They looked at the clinical efficacy and safety of TNK plus heparin or heparin alone in normotensive PE patients, what they called intermediate risk, and I'll get into a moment what that is. A fairly large trial, just over 1,000 patients intent to treat trial. The primary outcome was a composite of death or decompensation within 7 days of randomization. Death or hemodynamic decompensation within 7 days. I will show you the results trial. First, sorry, this is the table 1. First note that fairly elderly population, older than the two other trials that I showed you. This is primarily a European study, and that's a common feature in European sort of PE studies. But just note that this is the mean is 70, so half the patients are older than 70 in this group. Also notice that almost all of them had a CTPA, not a VQ, as their diagnostic test. And also notice that 50% of them had an echo done within 2 hours. It doesn't say that here, but that was within 2 hours. They had an echo done in order to diagnose this RV strain. Remember, they could have, anyway, okay. So here's the efficacy outcomes. Their primary composite outcome is right here, hemodynamic decompensation, right here. So, sorry, primary outcome is the top one right here. 5.6 versus 2.6. The composite outcome is death or decompensation, right? But there's no difference in death. The mortality is statistically not different, 6 versus 9. But their primary outcome is statistically significant because of the increase in hemodynamic decompensation. So their primary outcome, statistical significance, is driven completely by a higher incidence of hemodynamic decompensation. That decompensation could just be a drop in their blood pressure. It could be that they needed to go on inotropes. But it didn't result at the end of the day in any difference in mortality. So you can argue about what the clinical significance of that is. But look at hemorrhagic strokes. 2% of the TNK patients bled. There was actually 12 strokes, 2 were ischemic, and 10 were hemorrhagic strokes. There was only 1 in the control group. So that's a 10-fold increase in intracerebral hemorrhages for no mortality benefit. These are the same results. I just put them together in sort of what I think is a little bit easier table to appreciate. Placebo, this group of patients, so-called labeled submassive, had a mortality of 1.8% with just anticoagulation, no thrombolytics. The difference that was statistical was the hemodynamic compromise within 7 days. And there was the big increase in both extracranial bleeds and intracerebral hemorrhages. The death at 30 days was also no different. So the conclusions from the Pizzo study are that mortality for intermediate risk submassive PEs is actually lower than most people would think. So this whole group was 1.8%. And that's why it will be very difficult to do a trial in this population to show a mortality benefit, because you'd need a huge trial if that's your baseline mortality. There's no mortality benefit for thrombolysis. There is a tenfold increase in ICH with thrombolysis of around 2% or so. And the long-term morbidity and quality of life is unknown from this trial, as suggested in top coat, where the suggestion was that there are quality of life improvements, there are morbidity improvements, but this trial didn't really address that, so we don't really know the answer to that. The meta-analysis that was done last year, the Chatterjee Meta-Analysis, has created a great deal of controversy because of its conclusion, which I will show you. And I don't want to get into the details of it because it could take the whole hour to go through this trial. But I do want to point out a couple things. They did one of the analyses they did looks at just intermediate pulmonary emboli, and I think there are 8 or 9 trials that try and answer the question we're talking about right now, which is thrombolysis for submassive PE. But one of those trials, the Ultima trial, is actually a catheter-directed thrombolysis, not intravenous. And the other trial I will highlight is the Fazzulo trial, where if you look at the anticoagulation, that is the placebo group, they had 6 out of 35 patients die. That is way out of proportion to any other trial. If you exclude both of those trials, this no longer shows a mortality benefit. This just reaches the point with all these trials. If you take out the Fazzulo and you take out the non-IV thing, that actually crosses unity. So there's been a lot of controversy about this trial and what it actually shows. Most of these trials are small numbers, and almost half of them come from the one trial, the Pizzo trial, which I went through. The Pizzo trial in the New England Journal last year is probably our best current methodologically sound study to try and answer the question. Many of these earlier trials, some of them in their previous stuff are like from the 70s, probably should not be included. Here's the conclusion, taken right from the paper. Thrombolytic therapy was associated with lower all-cause mortality in patients with PE, including the subset of patients with hemodynamically stable PE associated with RV dysfunction. Right? So people have used this meta-analysis and basically run with it and say, there is meta-analysis proof that thrombolysis improves mortality. But there is no individual study, and there's no high-quality study which shows that's true. Earlier in the paper, he says, enthusiasm regarding a potential mortality advantage observed in the current analysis of thrombolysis agent in intermediate risk PE needs to be tempered with pragmatism, especially in view of the significant association with major bleeding noted. My conclusions from this review of the recent trials are the following. The current literature on this subject is early, and it's very noisy. It's very noisy because the interventions are different. Some are half dose, full dose, TNK, alteplase. The populations that they're studying are different. The outcomes they're using are different. It's very noisy. I do think there's a signal here, but I think from recent trials that I went through, I think it's still too noisy. I think we need more trials. Submassive PE, actually, if you take the whole group, and if you define submassive as normal blood pressure, but evidence of RV strain, dilated RV, bump in troponin, if that's your definition, that group as a whole actually has a 2%. There is no good quality convincing evidence in that population I just defined. There may be a signal of improved mortality in younger, higher risk subset of submassive PEs. And Drew the patients that he described are what I would call high risk submassive. They have not just a little dilation of the RV, they have big dilations of the RV. They don't have a little bit of a clot, they have They have large clot burden. They have blood pressures which are hovering in the 90-ish kind of things. They have had cardiac arrest. They've had CPR. Of the sort of what are being categorized as submassive PE patients. Thrombolytic therapy is limited by a necessary evaluation of the individual risks of serious bleeding and strokes. I didn't show the graphs here, but there is good evidence that high risk submassive group, the benefit risk may weigh in favor of thrombolysis. And I think a couple of papers or patients that Drew presented would fall in that category. But if you just use a very liberal, wide definition of what you call submassive, and they are older, then the risk-benefit may not be there. In fact, the risk of bleeding may be greater than any mortality benefit. I think we need significant answers to some important research questions. What is the role of reduced dosage protocols? Because the Moppet trial used half dose and showed significant hemodynamic benefits in pulmonary artery pressures with half the dose. So do we really need to use full dose like we use for a STEMI? Or can we get away with half dose TNK or half dose alteplase? What is the role of low dose catheter directed thrombolysis? The Ultimate trial is the only trial that looked at that. There's a big trial going on that's trying to address that. How to better risk stratify submassive PEs? Who are those people who are at higher risk where thrombolysis would be helpful? And what is the long-term effect of submassive PEs on patients' outcomes, quality of life, heart failure down the line, functional status? We don't know the answer to that. This is my last slide, and it's my own personal bottom line, having looked at the literature. I think thrombolytic therapy is not appropriate for all PE patients who are currently categorized as submassive by that definition that we liberally, they're not massive, but they have some element of RV strain. And if you take that group as a whole, I don't think we should thrombolyze all those patients. I think there is a role for thrombolysis in a small set of high-risk submassive PE patients after a careful and shared assessment of their individual risks and benefits of bleeding and benefits. And this is not an easy subject. The controversy will continue, and I hope everyone will stay tuned for new research in this area which will help sort out some of these questions we struggle with today. Thank you.
Okay, I'm just going to grab 4 or 5